Good afternoon, fellow colleagues from Singapore, Indonesia, and across the region. On behalf of the Singapore Society of Intensive Care Medicine, SICM, and the Indonesian Society of Intensive Care Medicine, ISICM, it is my great pleasure to welcome all of you to today's joint webinar on the ICU ventilation journey, best practices, and updates. I'm Yi Ting from Singapore, Sengkang General Hospital, and I'll be moderating this session together with Dr. Andy Mutya Pegarang from Indonesia, Central Pertamina Hospital. It's really nice to see colleagues joining us today from across the region, and today's session is a prelude to our APIC Symposium which will be held this year in Bali for the first time. Today's session will walk us through the entire ventilation journey, from choosing the right support, to protecting the lungs and diaphragm, to managing failure, and eventually winning safely. We have an excellent lineup of speakers today who will share with us their expertise. And before we begin, just a few housekeeping points. Please post your questions in the Q&A chat board throughout the session. Today's format consists of 4 focused 15-minute talks, followed by a 30-minute combined Q&A session at the very end. Hence, we'll try to address your questions during the final discussion segment. This webinar is also being recorded. Without further ado, I'll hand over the time now to Dr. Andy, who will introduce the first speaker of the day. Dr. Andy, please.
All right. Thank you, Dr. Yiting. Hi, I'm Andy, and we are about to start our the ventilation journey for today. But first, maybe I would like to remind all the participants to check out their chat box. There will be an attendance list that you can fill in. There will be a Google form link. And also for Indonesian participants, there will be an announcement about the Pelataran Sehat link that you can only be accessed tomorrow, maybe the fastest. Okay, so now we can start with our first lecture or talk of the day. Will be given by Professor Dita from Indonesia. The topic will be choosing the right support, non-invasive modalities, or intubation. Okay, I think it will be an exciting talk. Over to you, Prof. Dita.
Thank you, Dr. Andy, for the very nice introduction. So I will already request the slide share. Okay. Thank you also for the event organizer for inviting me to participate in this webinar. So as the introductions, the non-invasive ventilations, or NIV, has become a cornerstone in ICU management for acute respiratory failure. And the technology advances and strategies has expanded indications to optimize outcomes while reducing endotracheal intubation risk and shortening the hospital stay. So for the intubation reductions in respiratory failure, NIV has been shown to decrease intubation rates by approximately half and reduce ICU admission by half too. For cardiogenic pulmonary edema and COPD, the use of non-invasive positive pressure ventilation is associated with the decrease of length of ICU stay, while still remaining cautious. As predictor, it's important to identifying early physiological marker of failure to improve the patient outcome. CPAP or NIV itself has a gradation between mostly patient work to mostly device work through breath support augmentations, through ventilation support, without using an invasive artificial airway. Over the last decade, the technology has transitioned from basic pressure to sophisticated system that capable of sensitive triggering, leak compensations, and making it more viable and useful for critically ill patients. It's also included improving patient ventilator synchrony and more comfortable interface design, which mitigate the problem of patients' intolerance. NIV is strongly recommended as the first for acute hypercapnic respiratory failure in COPD to reduce intubation risk and mortality. In cardiogenic pulmonary edema, NIV rapidly improved distress, hypercapnia, and oxygenations versus oxygen alone, of course, with a confirmed can lower mortality. For hypoxemic failure, the benefits are seen in milder cases. For example, like PF ratio more than 200 millimeter mercury. Although severe ARDS still has limitation of efficacy. The NIV also prevents reintubations in some severe high-risk patients. Using the NIV, we can avoid the sedations, lower the risk of ventilator-associated pneumonia, and the patient able to communicate and swallow. But we have to be aware of risk of facial skin injury, gastric insufflations, and the potentially fatal delay of necessary intubations when the NIV fails. What's still uncertain is NIV is highly effective for hypercapnic failure, for example, like COPD, but in hypoxemic severe ARDS remains controversial. We should closely monitor the Hacker score, for example, like heart rate, acidosis, consciousness, oxygenations, and respiratory rate to predict whether the NIV failed within the first 1 to 2 hours of the treatment. Next, high-flow nasal canal. High-flow nasal canal can reduce intubation rates and mortality in specific patient subgroup while offering superior comfort compared to the conventional oxygen therapy and non-invasive ventilation, the NIV. It delivers precise oxygen concentration at high flow rates up to 60 liters per minute, while provides a low level of positive and expiratory pressure and effectively washes out anatomical dead space. The principle of high-flow nasal canal, the primary components of it include an air-oxygen blender, an active humidifier, and a heated circuit. The system can deliver warm up to 37 degrees of Celsius and fully humidified gas at flows between 30 to 60 liters per minute. And this high flow match or exceed patient's demand, while ensuring the delivered oxygen fractions remain constant and it is not diluted by the room air. The key finding of high-flow nasal canal, trials demonstrate that it significantly reduced the need for invasive mechanical ventilations in patients with severe hypoxemia. It provides physiological PEEP by generating a flow-dependent PEEP effect, typically ranging from 2 to 5 centimeter water, which help maintains alveolar recruitment. For the dead space washout, by delivering high flow rates that exceed the patient's inspiratory peak flows, the high-flow nasal canal clears carbon dioxide from the upper airway, reducing the work of breathing of the patients. Recent reviews suggest that high-flow nasal canal is not inferior to the NIV for preventing reintubations after the extubations and can managing mild to moderate hypercapnic failure. We know the ROX index, calculated as the ratio of oxygen saturation to oxygen fractions divided by respiratory rate for predicting high-flow nasal canal success versus the need for the intubations. The clinical application of high-flow nasal canal for acute hypoxemic respiratory failure produce better oxygenations and reduce work of breathing. For post-extubations in high-risk patients, the combination of high-flow nasal canal and NIV or high-flow nasal canal alone has been shown to be effective in preventing post-extubation respiratory failure. In pre-oxygenations, high-flow nasal canal is increasingly used during intubation procedure to provide apneic oxygenations and by extending the safe apnea time. For the practical takeaway, usually we start high, begin flow at the 40 to 60 liters per minute, and then titrate based on patient comfort and the respiratory rate. We usually monitor the ROX index, which is a ROX index equal or more than 4.88 in 12 hours, is generally associated with a lower risk of the failure. For the temperature settings, we keep the humidifier at 31 up to 37 degrees Celsius to optimize comfort and ciliary clearance. High flow nasal cannula is an excellent for bridging patient from the NIV or from intubation or immediately following the intubations. Using the high flow nasal cannula, we can enhance patient comfort. Patient allows eating and speaking and have reduced mucosal dryness and precise oxygen fraction delivery. We should be aware and careful with high oxygen consumptions, potential for delayed intubations if monitoring is inadequate, and a limited airway pressure or PEEP compared to the NIV. What's still uncertain is delayed intubation remains a major concern. We use the ROX index at 2, 6, and 12 hours to guide the decision-making whether we have to exhalate or intubate. The NIV are comparable to high flow nasal cannula in terms of the oxygenations, comfort, ICU stays, and mortality. The NIV itself benefits in patients after extubations or in hypercapnic mixed failure patients, while high flow nasal cannula is better for hypoxemia patients without excessive effort. We should avoid prolonged high flow nasal cannula beyond 24 up to 48 hours without improvement, as switching to NIV that can shorten ICU stays in severe cases without excess risk or comorbidity and complications. High flow nasal cannula is superior in tolerance, reduce the respiratory distress in patients, and delay intubations without the potential harm of NIV. For example, like less gastric distensions, less aspiration risk. But the NIV may still benefit in selected hypercapnic or post-extubation cases. However, some data prefer high flow nasal cannula initiation in immunocompromised ICU patients with acute hypoxemic respiratory failure, and some studies consistently favor high flow nasal cannula over the NIV as a first-line therapy, showing lower intubations and mortality rates less than NIV as the first line. The NIV itself independently increase the risk of intubations, possibly due to delayed escalations or patient interface intolerance. The 28 days mortality is also lower with high flow nasal cannula than with NIV, almost threefold higher mortality with NIV. This ICU mortality seems more with NIV linked to the prolonged ICU in more severe conditions. When we should escalate or intubate the patients. Switching from high flow nasal cannula to NIV to intubations is defined by a specific clinical and physiological threshold observed within 1 to 2 hours after the initiation to avoid delayed intubations. Late failure more than 48 hours may worsen the outcomes. We should look for the increase of work of breathing, altered mental status, for example, like GCS level drop or shock, and escalate if sign of the failure emerge, such as our ROX index failing below 4.88, as this value predicts the needs for intubation with high accuracy. And also we look for persistent severe hypoxemia, higher respiratory rates, or worsening PF ratio despite the maximum flow and oxygen fraction given, or the sign of high inspiratory effort like using accessory muscle should be as an indication for quick intubations. Late NIV after the high flow nasal cannula may improve the oxygenations, but usually doesn't improve the ICU stay, averagely prolong up to 4 days ICU stay, then NIV directly apply as an initiation. The ROX index is superior as a single variable of when we should escalate or intubate compared to a respiratory rate or PF ratio. The low ROX index is a sign for escalations to NIV and intubation, which is we know that early intubation less than 24 hours from NIV improves survival versus late more than 24 hours up to 48 hours. And we know that avoiding prolonged non-invasive support will avoid harms in non-responders. So the intubations after NIV failure, after high flow nasal canal initiation in hypoxemic respiratory failure should occur promptly, ideally within 1 to 2 hours of initiation or no later than 24 hours. The guidelines stress predefined failure criteria and early intubation in non-responder to either high flow nasal canal or NIV to avoid harm from delayed intubations. So I think my presentation is quite quickly, yeah. So the practical bedside summary, we can start high flow nasal canal in acute hypoxemic respiratory failure, for example, like pneumonia, in immunocompromised patients with very close monitoring, ROX-based monitoring. And we can reserve the NIV for patients, especially with high effort or hypercapnia, where you need a stronger unloading the carbon dioxide. And for both modes, failure after 2, 4, 6, or 12 hours of optimize the setting with the persistent severe hypoxemia or distress, it should trigger for the intubations, planning rather than prolong the non-invasive trial. So thank you for all your time. So we are looking forward everyone in EPICS Bali on July 2026. Thank you.
Thank you so much, Prof. Dita, for your insightful talk on when to choose the right support. That talk was really very clear and very helpful for all of us. Just a reminder to the participants joining us today, do continue to post your questions in our Q&A chat board, and we'll try to address these questions towards the very end at the Q&A segment. It is now my pleasure to introduce our next speaker, Dr. Sim Wen Yuan. Dr. Sim is a senior consultant intensivist in the Department of Respiratory and Critical Care Medicine from Singapore Tan Tock Seng Hospital, and today he'll be sharing with us on the topic of lung and diaphragm protective ventilation. Dr. Sim, thank you for joining us today, and the floor is yours.
Thank you. Thanks, Siti. So the slide visible?
Yes, it's visible.
Okay, thank you. Thanks for the invitation. Today we're talking about lung and diaphragm protective ventilation. So I have no conflicts of interest. This is an overview of my talk. I'll first speak about on how the goals of ventilation have evolved over time, and then I'll spend the bulk of the time talking on the concept of lung and diaphragm protective ventilation and how we can go about trying to achieve this. So these are the objectives. We'll discuss the rationale for diaphragm protection alongside lung protection, and then we'll describe approaches to monitor both effort as well as lung distending pressures so that we can evaluate the adequacy of our strategy for diaphragm and lung protection. And then we'll also discuss how we manage patients with excessive drive, excessive effort, and therefore injurious lung distending pressures. So moving to how the goals of ventilation have evolved. I think in the 60s and 70s, the major goal of ventilation was to maintain actually near normal blood gases. So volumes that were used were not uncommonly quite large, 10 to 20 mL per kg of actual body weight, and obviously they got very high airway pressures as a result. In the 80s and 90s, there was this recognition that the forces in the lung that were caused by these large volumes can cause harm in the form of villi, as well as impact hemodynamics, and that actually some degree of respiratory acidosis is actually quite well tolerated. So this led to a change in focus. Wanted to minimize the harm using lung protection and maintain adequate rather than completely normal blood gases. So I think over the next few years, we've had numerous publications that have demonstrated that being lung protective has improved outcomes. And I think most famously that everyone's familiar with the ARMA trial from 2000, that was in the NEJM. So these other studies have kind of informed our targets for lung protection. We target an adequate PEEP for recruitment or limiting overdistension. We want to get tidal volumes between 4 to 8 mils per kg or driving pressures below 15. We're going to limit our P-flats to at most 20 to 30. And over the last few years also, we talk about a lower rate to potentially reduce the mechanical power of ventilation. And we also target not completely normal blood gases, but something that is more moderate. So we tolerate some degree of hypoxemia and some degree of hypercapnia. So I also want to highlight that it's not just the pressures and volumes that are delivered by the ventilator that play a role in VILI, and patient effort can also contribute to VILI. The diagram on the left shows a patient with respiratory distress on positive pressure ventilation and inspiration. So here there's a large patient effort and a large negative swing in pleural pressure of negative 15. And this leads to a very high and injurious transpulmonary pressure of 25, even though the airway pressure is only 10. So this is the concept of patient self-inflicted lung injury, or PFILI, which is lung injury that is contributed by the patient's own, often excessive respiratory effort during ventilation. And the diagram on the right describes this vicious cycle of lung injury that can be perpetuated by increased patient effort and drive. So it may thus be more appropriate to use the term ventilation rather than ventilator-induced lung injury. This is a broader term that refers to lung injury that results from ventilation, whether this ventilation is positive pressure due to the ventilator, negative pressure due to the patient, or a combination of the ventilator and the patient. So we covered the first two goals of ventilation, achieving adequate gas exchange and also protecting the lung. This concept of diaphragm protection as another goal of ventilation has emerged over the last few years. So this image actually shows 4 different forms of what's termed ventilator-induced diaphragm dysfunction or diaphragm myotrauma. Kind of want to focus on two forms. Overstimulated myotrauma, which results when you have too much sedation or too much ventilatory support that can actually suppress or reduce drive and effort and leads to a disuse atrophy of the diaphragm and potentially prolonged bleeding. At the opposite end, you have under-assistance myotrauma. You have too little sedation, too little support from the ventilator, resulting in excessive drive and effort, and this can result in acute diaphragm injury and contractile dysfunction. And then this ultimately also can result in prolonged bleeding. So there's some evidence that diaphragm myotrauma may contribute to clinical outcomes. So in this study, in this diagram shows the duration of ventilation on the y-axis, and this varied with the level of inspiratory effort on the x-axis during the early course of ventilation. So this study, they used ultrasound to define inspiratory effort. They basically looked at the diaphragm thickening fraction. So duration of ventilation is prolonged in patients with either relatively low average levels of inspiratory effort or patients with relatively high inspiratory effort. And the shortest duration of ventilation was observed in patients with intermediate levels of effort. So I think hence one of the major goals of diaphragm protection is to maintain a modest inspiratory effort, prevent both over-assistance myotrauma as well as under-assistance myotrauma. So you kind of want to get a Goldilocks zone where the effort is not too high and not too low. So moving on, how do we achieve lung and diaphragm protective ventilation? I think that the concept of this concept makes ventilation more challenging. So previously we only had to think about gas exchange and lung protection, but this introduces an additional dimension. You also have to think about the diaphragm. Right? So in order to achieve this, you need to assess and attend to gas exchange, lung descending pressures to see whether you are being adequately lung protective, as well as patient inspiratory effort to see whether you're being adequately diaphragm protective. So the gold standard for this is the use of esophageal pressure measurements. And this is the reference technique for real-time monitoring of both effort as well as global lung stress during mechanical ventilation. So for example, with the esophageal manometry, you can measure the decrease in esophageal pressure during inspiration, or the delta PES. And this is a measure of inspiratory effort. So by measuring this, you can tell whether you're being diaphragm protective. You can also measure the change in transpulmonary pressure between expiration and inspiration. This is termed the dynamic transpulmonary driving pressure, and this is a measure of global lung stress. And again, you can use this to see whether you're being lung protective. So these are potential targets that you can aim for, try to achieve both lung and diaphragm protection. So with diaphragm protection, you want to achieve a delta PES of between -3, -12 cm of water, potentially down to -15. And for lung protection, you want to achieve a dynamic transpulmonary driving pressure of below 15 to 20, maybe up to 22. So I think these are potential targets the exact values are not fully defined yet. And I think there's ongoing work in this space. However, I think we also know that the esophageal catheter is not widely used, and I want to introduce the concept of the occlusion pressure, the POC, which is a non-invasive alternative using NXP occlusion maneuvers that you can do on any ventilator. So what is POC? This is actually the drop in airway pressure during inspiratory effort against the random occlusion. So it's a random occlusion. The patient doesn't know it's about to happen, so there is no change in effort from the previous or subsequent breaths. The caveat is that this can only be measured in a patient with a cuff tube on an ICU ventilator, and leaks, for example, through the cuff or through chest tube, can result in underestimation. So conceptually, what happens is that you're applying an NX3 occlusion, and the patient is unaware of this. The patient makes an inspiratory effort against the closed airway, and you measure a drop in airway pressure during this effort. And that is the occlusion pressure, the POC. So what is measuring? Basically, when the patient attempts to inspire against this occluded airway, there's no flow, no change in volume. So drop in airway pressure is equal to the drop in esophageal pressure. And then you can then use the POC to estimate the inspiratory effort. So the predicted drop in esophageal pressure is 2/3 times the occlusion pressure. So why 2/3? So I think this is because the drop in airway pressure during occluded breath is greater than the drop in esophageal pressure for the preceding and subsequent breaths, because for occlusion lasting more than 0.3 seconds, the patient senses the occlusion and may actually increase the effort in response. Also, for an occluded breath, the diaphragm is in a more mechanically advantageous position because it doesn't descend, so it generates more force. And therefore, you need to apply this correction factor of 2/3 to determine what the esophageal pressure drop is. Using the occlusion pressure also allows us to assess if you're being non-productive. You can do this by calculating a predicted dynamic transpulmonary driving pressure, which is calculated as the P peak minus PEEP and minus the 2/3 times the POC. Again, as I mentioned earlier, targets are not entirely clear. One value has been quoted as below 22. Here I'll just show an example of how this can be used at the bedside. So this is a patient on PSV of 12 over, sorry, PSV of a PS of 15 and a PEEP of 12. And I'm going to measure the POC. So I'm using the NIF function to measure the drop in airway pressure during an occluded inspiration, and it's -10. Right? So POC is -10. If you want to calculate the predicted drop in esophageal pressure, it's 2/3 times -10, so -6 or -7 cm of water. If you want to calculate the real dynamic transpulmonary pressure, then I add 15, which is the pressure support, to this -6 to -7, and I get about 222. And ideally, you want to be below 22. So that's how you can potentially use POC to assess your adequacy of diaphragm and lung protection. So what are the challenges involved in achieving this? I think in the early phase, in patients with more severe respiratory failure, we often use deep sedation and sometimes paralysis to facilitate strict lung protection, and patients are at risk of diaphragm disuse atrophy. When we then stop paralysis and wean sedation, many patients transition to exhibit very vigorous efforts and therefore very high lung standing pressures, and they're at risk of both lung injury as well as diaphragm injury. So in this setting, what can we do about these excessive efforts and excessive lung standing pressures? These are possible interventions. You can titrate pressure support, titrate PEEP, increase FiO2, adjust your analgesia sedation, potentially use partial neuromuscular blockade, or in some situations you have no choice but to go back to fully controlled ventilation by resuming deep sedation and paralysis. So I'll talk about a bit of these in turn. So how do you calculate pressure support? I think this diagram depicts a conceptual model describing how your tidal volume varies as a function of amount of support in pressure support. And within a certain range of pressure support, the patient will compensate at any change in assistance by an opposite change in effort in order to maintain the patient's desired volume. So this can be a bit frustrating. So for example, when you have a patient with high tidal volumes and high descending pressures, you try to reduce the pressure support, reduce the volumes and the pressures, but the patient then often compensates by increasing effort. And then the tidal volume and the pressures descended lung are unchanged. So pressure support change may not always result in what you want. Another alternative is to adjust the PEEP. Again, it's challenging because the effect of PEEP varies depending on how the PEEP affects the lung. And an increase in PEEP may result in a decrease in effort and decrease in descending pressures only if the PEEP improves compliance. And this was demonstrated in this paper from CHEST 4 years ago. Another option is to actually increase the FiO2. So we've been taught traditionally that PaO2 is not a strong stimulus of drive until the patient is quite hypoxemic, PaO2 below 60, flat or below 90. But this may not necessarily apply to critical ill patients. There are a couple of studies, quite old studies, that show that if you're targeting a high normal PaO2, by increasing FiO2 can actually help to decrease inspiratory effort and descending pressures. Next option may actually be to adjust analgesic sedation. So we know that cortical or suprapointal inputs like pain, discomfort, anxiety can result in increased drive and effort. And in some patients, you can address these with agents like opioids, ketamine, maybe dexmedetomidine. However, in other patients, you may actually need deeper sedation with GABAergic agents like propofol to attenuate the ventilator response to hypoxemia and hypercapnia. I kind of want to highlight that different agents have different effects on drive, effort, and the breathing pattern. So the GABAergic agents like the propofol and the benzos cause respiratory depression, and this is primarily by reducing the amplitude of the effort. And we all know that benzos cause more delirium, so we tend to prefer propofol. So to illustrate this, the effect of propofol, you look at what's highlighted on the left. In a patient on PSV, with increasing propofol dose, the magnitude of drive and effort are reduced, but the rate remains the same. This is in contrast to opioids. So opioids primarily depress the rate, but actually may not change the magnitude of drive or effort. Again, in this example, with increasing dose of remifentanil, the rate is reduced, but the magnitude of the drive and effort is actually unchanged. I also want to highlight that if you're titrating sedation to control effort and descending pressures, you actually need to monitor drive and effort and titrate the sedatives accordingly. So you cannot target deeper sedation, like a lower RAS, and assume that drive and effort will be lower with deeper sedation. This is shown in this study where there was no correlation between the depth of sedation as measured by RAS and the respiratory drive as measured by the P.1. So there's no correlation at all. Another option may actually be partial neuromuscular blockade. This was a small proof of concept study that showed that potentially in someone on pressure support, you can give partial paralysis with a lower dose of rocuronium in this case to decrease the volumes. I think this hasn't been replicated yet, so probably not ready for implementation yet. And if all else fails, I think you have to consider resumption of deep sedation and complete neuromuscular blockade. And again, the suggestion is that given the evidence that we have now, I think the lung should be a priority over the diaphragm because we know that the lung is, we have stronger evidence that lung protection is beneficial. Right? So there may be a population of patients with severe acute respiratory failure in whom you cannot achieve lung and diaphragm protection and you have to forgo the diaphragm, go back on deep sedation and paralysis and for straight lung protection. So as we come to the end of the talk, I just want to say this is the conceptual framework of lung and diaphragm protective ventilation. It is hoped that by paying attention to gas exchange, lung protection and diaphragm protection, we will improve overall patient outcomes. There are currently 2 trials that have looked at the strategy of lung and diaphragm protection in adults. The first trial concluded that if you titrate inspiratory support based on patient breathing effort, this actually can increase the amount of time that the patient had the diaphragm effort in the so-called predefined diaphragm protective range without compromising volumes and transpulmonary pressures. Another paper concluded that if you titrate ventilation and sedation, you can optimize respiratory effort for lung and diaphragm protection in most patients. So I think these 2 trials show the feasibility of implementing this, and we await further studies in adults with patient-centered outcomes. So to conclude the talk, I'll take home messages. During invasive ventilation, I think we should pay attention to gas exchange, lung protection, and diaphragm protection. Surfacial pressure management is the reference standard for monitoring both inspiratory effort and lung descending pressures. It's not available to all of us. I think the occlusion pressure is a non-invasive alternative that can be measured on all modern ICU ventilators, can give you predicted delta PES and predicted transpulmonary driving pressure. If the inspiratory effort and descending pressures are excessive, these are some options you can use. You can titrate pressure support, titrate PEEP, increase FiO2, adjust your sedatives and analgesics, consider partial blockade, and in some situations you have no choice but to go back to fully controlled ventilation. And when conflicts arise, I think lung protection should take priority over diaphragm protection because of the established mortality benefit that we know comes with lung protective ventilation. Right. Thank you.
Right, thank you so much, Dr. Sim, for your insightful talk and for sharing with us the importance of thinking about diaphragm protection and also sharing with us on the various strategies to avoid ventilation-induced lung injury. So similarly for all our participants joining us today, do continue to post your questions in the Q&A chat board, and we will try to address them as much as possible during the Q&A segment at the end of all the talks. So it is now with great pleasure that I introduce the next speaker, Dr. Sewa Duwan. Dr. Sewa is the head and senior consultant of the Department of Respiratory and Critical Care Medicine at Singapore General Hospital. Today, he'll be sharing with us on the topic of when conventional ventilation fails. Dr. Sewa, the floor is yours.
Thank you, Dr. Tang, for the kind introduction and for the True Society to extend the invitation for me to give the talk today. So I'll just jump straight in to the given talk for me this afternoon. So I'm going to discuss some of the concepts regarding protecting a patient on mechanical ventilation and how best to actually provide the support. And also to talk a little bit about beyond the conventional mechanical ventilation. So I have no disclosure financial disclosure relevant to this talk. I do want to note that some of the infographics that I've used was created using a generative AI. So these are the scopes that I'm going to discuss. I'm going to use acute respiratory distress syndrome as the prototype of the respiratory failure condition, where we applied most of our concepts for mechanical ventilation, our goals, and what is important. And we are going to use this as a means to discuss the various concepts on how we are currently doing conventional mechanical ventilation and what has been proposed as the way to personalize our titration of mechanical ventilation based on the individual patient's mechanics. And there are certain group of patients that unfortunately, despite our best effort, do have refractory hypoxemia, or they are on injurious lung setting that we may have to consider extracorporeal to support the system. And currently, there are two main modalities of extracorporeal support system. One is the VV ECMO, venous ECMO, and the other is the extracorporeal, the CO2 removal devices. And there are quite a number of current randomized controlled trials to inform us in terms of its role in managing this group of patients. And I'll end with just a very short comment on the future of personalized ventilator titration. So I think everyone is familiar with the original descriptions of ARDS. And I think in the original publication in 1967, where the author identified a group of patients during the one of the Vietnam War, where they suffered from severe hypoxemic lung injury, where they shared similar phenotypes regards to oxygenation defect, loss of lung compliance, severe alveolar infiltration, as well as evidence of diffuse alveolar damage on autopsy. And over the last 30 years, there has been various alterations to our definitions of ARDS. And this is just the latest iterations published in the Blue Journal in 2023. I think the important thing that I want to highlight is not really the definition itself, but how this definition actually inform readers regarding the heterogeneity of this condition, right? It is still the syndrome, so it's not a disease entity by itself. There are different etiologies which can share the similar phenotypes. And there are also the efforts to categorize the severity. And one of the ways that the severity of the ARDS inform us in terms of not just the prognosis, but also to inform us regards to the therapy that may be suitable for patients with mild to severe ARDS. And just to highlight the point about heterogeneity, we do know that ARDS is a very heterogeneous disease, not just in terms of etiology, but also in terms of the severity of the lung involvement, ranging from very confluent consolidations to partial consolidations, with area of the lungs that are termed baby lungs, which are largely still preserve a compliant area where ventilation can preferentially flow. So when these patients are put on mechanical ventilation, there is a differential flow as well as a perfusion due to this heterogeneity. And all our attempts in our conventional mechanical ventilation to support this patient do affect the patient differently depending on how severe the lungs are involved. So I think our concept of baby lung is not quite well known to this group, and how we try to protect this baby lung is really to pay attention to the various ventilation to induce a lung injury by avoiding barrel trauma, epileptic trauma, volume trauma, and more recently the concept of ergo trauma, which is the mechanical power that's delivered to the lung. And I'll talk a little bit about how this concept may have informed us in terms of how we apply mechanical power to our titration of mechanical ventilation. But the key thing is to note that the ARDS lung is not inherently stiff, but it is actually functionally small. So what is our goals? Our goals really to mechanical ventilation is really to relieve the patient from the excessive workload of breathing due to increased burden imposed by the underlying disease process. We do want to support adequate gas exchange so that we can avoid hypoxia. And we do note the heart-lung interactions, and our mechanical ventilations do alter the heart-lung interactions, and with specific alterations to the hemodynamic status of the patient. And importantly, we want to avoid iatrogenic injury due to the concept of ventilation to induce lung injury. And as mentioned by the earlier speaker, diaphragmatic lung injury as well. So in our current context, what is conventional mechanical ventilation? So I think that this is something that we have known in the past 20, 30 years in terms of how we should manage our patients with ARDS in terms of using lung protective tidal volume, maintaining the plateau pressure below the 30 centimeters of water, conservative fluids as informed by the FACTS trial in terms of reducing pulmonary edema and reducing the length of mechanical ventilation days and hospital day. Proning has been shown to reduce the risk of mortality in the patients with moderate to severe ARDS. And there's suggestions that pharmacological blocking, neuromuscular blocking agents like cisatracurant may have effect in moderate to severe ARDS to reduce their mortality. But what we have realized is that the protective ventilation, as what I've mentioned, does not really protect the heterogeneous lung due to the heterogeneity in which ventilation and perfusion occur. So that there are areas of the lung where we are under supporting, and there are areas of the lung that we may be over supporting, resulting in over distension, increase in volume trauma, as well as transferring excessive mechanical power to those baby lung. And this is quite an old paper, but instructive in the sense that when they look at different severity of ARDS and they map out on CT the various ventilation images, they know that for the same degree of pressure and volume, they could have very varied degree of over distension and under the severe atelectasis. So it is important that we actually adopt precision breathing and personalizing our mechanical ventilation. And I think what has come out in the last decade is this concept of driving pressure. And this driving pressure has been increasing use in many units as well as clinical trials to really help us further normalize our delivery of our pressure based on the patient's compliance. Right, so the driving pressure conceptually is actually tidal volume normalized to the patient's compliance. And mathematically, we can derive this by looking at the plateau pressure to peak pressure, the difference. So this index actually represents a dynamic cyclical strain. And it is one of the strongest predictor of mortality, even performing a better relative to tidal volume as well as the plateau pressure in the Amato trial that was published in NEJM quite a while ago. And the concept of transpulmonary pressure has been alluded by the performer, the speaker. So we know that when we measure plateau pressure, we are measuring the whole respiratory system, but it doesn't really distinguish between the stiff lung from a stiff chest wall. So in certain patients with severe obesity or intra-abdominal hypertension, this plateau pressure could be excessively high. And the way to really tease out what is important is by measuring the esophageal pressure as mentioned by the previous speaker. So the esophageal manometry is usually is actually acting as a surrogate for the pleural pressure. And using that to really calculate the transpulmonary pressure will help to prevent dangerous overestimation of the lung stress in certain group of patients so that we can reduce inappropriate PEEP or tidal volume. And in the exploratory publication in the NEJM quite a number of years ago, this group of authors actually used esophageal pressure catheter to try to fine-tune the esophageal, the mechanical pressure that's delivered to the patient compared to a controlled group where they are ventilated with a low PEEP strategy. And that has been shown to actually effect a significant change in the way that the clinicians manage the patient's PEEP, and also it may have importance of physiological advantage in reducing the lung injury. However, when this was extrapolated to a larger phase 2 randomized controlled trial in a larger group of patients using esophageal guided PEEP, unfortunately, it was a negative clinical trial showing no difference between PEEP guided esophageal guided PEEP titration versus a group of patients who are ventilated on high PEEP. But when they reanalyze this clinical trial, there are the potential usefulness when we actually target a certain phenotype of the patients. So in the patients with a low Apache score, the use of esophageal guided PEEP may have some advantage, increasing the survivorship with a P value of 0.03. And when they reanalyze mechanistically what is the target for the transpulmonary pressure, if you are able to keep the pulmonary pressure within plus or minus 2 centimeter, that seems to be really correlate with mortality. But obviously, we need better clinical trial to inform us whether the use of esophageal pressure would have advantage improving the survivorship. The other concept is really improving recruitability. We do know that in severe ARDS, there are many areas of the lungs are atelectatic. And the recruitment of these areas, not only does it improve perfusion, but also improve the VQ matching. And there are many attempts in the past to use various modalities to try to estimate or guesstimate the recruitability. And CT imaging or ultrasound has been advocated in certain countries. But even in Singapore, we do not have an in-house CT scanner. So it's difficult to do this logistically. The PV curve measurement can be used to assess the recruitability, but that is also something that very tedious. What has been actually proposed in the last decade is really this new index called the recruitability inflation ratio, as well as the use of electrical impedance tomography. So in this very busy slide, this is just how this recruitment to inflation ratio is being done. So the concept is basically that we are trying to look at the ratio of the compliance of lungs that are recruited over the baseline compliance at low PEEP. And a high recruitment to inflation ratio predicts a very high recruitable lung. And in this kind of context, you may actually adopt a higher PEEP strategy to try to reopen the collapsed alveoli. So I have left the reference as well as the web page to one of the group investigators published website, which actually inform everyone through how this recruitment to inflation technique can be done. EIT is not something that I've used personally, but has been advocated to use map-based computer imaging to look at regional compliance. And that has been shown to allow the clinician to visualize the exact cross point between the ventral overdistension as well as dorsal collapse. And that may be a strategy for one to actually further titrate your PEEP on the bedside. The last thing about personalization is really mechanical power. So this is a concept that was popularized by the late Gattinoni. And the basic concept is that a composite formula incorporating factors such as respiratory rate, tidal volume, peak airway, the pressure, as well as the plateau, the pressure, may be able to inform the risk of your mechanical energy delivery. So that the higher the energy level, the more consistently it has been linked to increase mortality. So how would you use this in the clinical setting is still not quite well defined, but at least it gives a kind of a global index on how the potentially mechanical power can be incorporated, can incorporate all these indices into a single index for you to gauge whether you are doing harm to your patient. We also know that the ARD has a different phenotype, and the hyperinflammatory phenotype was well described by Cafe and group. And basically, this a group of patients with ARDS that is manifested with high cytokines, low compliance, and severe shock. And it was found that in this group of patients, these are patients with more recruitable lung and may respond better to higher PEEP as well as conservative fluid management. So in the event that we are faced with total lung failure, the ECMO, which is extracorporeal membrane oxygenation, is probably one of the rescue salvage therapy where blood is drained from the patient's body, put through an artificial lung, oxygenated, and CO2 is being removed before putting it back to the patient. And it decouples the gas exchange from the lung so that we can achieve significant lung rest. And the two modern clinical trials, the CSER as well as the ILLUR trial, unfortunately, they have a conflicting kind of information. But I think overall, the important concept in the disease group of patients with refractory hypoxemia, selecting patients with very severe hypoxemia or hypercapnia despite lung rest may be able to rescue and salvage. But importantly, we need to select a group of patients and we need to time the delivery of ECMO so that this is done in a timely fashion and not late into disease trajectory. Because the later that we initiate the ECMO, the more severe the patient's mortality will be. There are many contraindications, and very often these are also the site-specific, although they are general principles. And I'll leave everyone to take a look at what are the general concepts. And the survivorship is still something that we are still debating on, but at least from a meta-analysis standpoint, I think ECMO seems to confer survival benefit. And it's important that these are done in larger centers because the volume do determine the outcome, as this is very complex teamed therapy. And we do know of the multiple various complications associated with ECMO. So if we can't achieve ECMO, we don't really have the capability to achieve ECMO. People have talked about just doing the CO2 removal. And basically, the concept is that by removing the CO2, you are able to achieve a better control of the respiratory acidosis so that we can adopt the ultra-low ventilation to reduce the mechanical ventilation setting. And by reducing the tidal volume, reducing the driver pressure, reducing the plateau pressure, we hope that we can reduce the mechanical power and change that to improve the patient outcome. And preliminary, the exploratory trial seems to suggest a benefit, but unfortunately, the recent publication of the REST trial do give us a pause in terms of the utility of ECOR, as there was no survival benefit, but there was an increase in terms of complications such as bleeding, as well as increased ventilation duration and labor cost. So it is difficult to really say what is the role of ECOR in this modern era. Most guidelines currently say that you should only attempt CO2 removal in the clinical trial, but hopefully with better precision in terms of selecting the patients, better delivery of our anticoagulation, as well as improvement in technologies, we'll be able to improve the patient's outcome with ECOR devices. Just a last note, I think there are many complex interactions between what we do. And I think the ultimate wish is that with assistance from machine learning, we can incorporate all these multiple very complex indices and using AI to help us in our decision-making process so that we can actually be more targeted in terms of our approach in delivering the mechanical ventilation. And hopefully, by addressing all this heterogeneity, as well as more targeted precision delivery of mechanical ventilation, we can eventually improve patients' outcome. With that, I will stop here and thank you for your attendance and happy to take any questions. Thank you.
Okay, thank you, Dr. Sewa, for that comprehensive talk on the strategies that we can do when conventional ventilation fails, especially in severe ARDS patients, and highlighting the importance of monitoring transpulmonary pressure, recruitability, overdistension, and mechanical power to be able to give an individualized and ventilation strategy, and also the role of ECMO and ECCOR. All right, moving on to our last speaker for today. But before that, I would like to inform for the participants that for the participants who are late in joining the talk, you can also review the talk in the YouTube channel Perdici Official, PERDICI. So you can watch the previous talk. So now I would like to introduce Dr. Adri Sugiarto from Indonesia, who is going to give the talk about the end of the ventilation journey, which is weaning and extubation. Dr. Adri, the floor is yours.
Thank you, Dr. Andy. So I'll try to share my slides. Okay. Hopefully you could see my slides. So I will talk about weaning and extubation. Thank you for inviting me. So we are already at the end of the journey for patient with mechanical ventilation, right? So we see the stages of patient on mechanical ventilation. They are begin with the admitted to the ICU, intubated, then having a mechanical ventilation, that we treat the patient, then we see the patient is getting better. We suspect this patient could breathe by himself. So we try to wean the patient and we try to do the spontaneous breathing trial. We try to extubate. If we are successful, the patient could be discharged. But if unsuccessful, the patient could be reintubated. This is the journey of the patient with mechanical ventilation. But about weaning and extubation, we see from the data that not all patients can be weaned or extubated early. I mean early within the 24 hours after the admitted to mechanical ventilation. Some patients need about 2 to 6 days to be weaned and extubated. Some patients need more than 7 days, and some patients could not be weaned actually, Joe. So the patient will remain mechanically ventilated for the rest of the visit in the ICU. So when the patient have a delayed weaning and extubation, we have another problem because they are associated with the higher mortality and longer ICU stays and bigger costs and increased ventilator-related complication. So when we are talking about weaning, I would like to limit the topic on weaning up until before the extubation, until the spontaneous breathing trial, because we have another part when we'll talk about the extubation. So we are doing weaning from the ventilators. We are usually use several indices to judge whether the patient could be weaned or not. Is it already powerful in breathing by himself or not? Is it any problem stay in the lung or not? So these are the indices that we could use. From the indices, we could also explore more numbers that we have that could help us to assess the patient whether the patient could be weaned or not. But if you notice all the numbers or the indices mostly are derived from the respiratory only. So we only focus on how the lung function, how the patient breathes, only on the respiratory part. Even though we know there are interaction between respiratory and other function of the body, including, for example, the cardiovascular system. So if you see, when we wean the patient from the ventilators, we try to decrease the power that the ventilator gives from the breathing pattern, we are doing some effect on the cardiovascular system also. For example, if you see in the slide, when the patient is breathing by himself, we induce a negative intrathoracic pressure. We will increase the venous return. We will increase the preload, and we will increase the central blood flow. If the patient have a limited left heart function, maybe the patient will have the problem that will arise from the weaning process of our patient. So the patient could have a lower lung left ventricle compliance, probably will have until up pulmonary edema. So all this process could involve when we are doing the weaning process of our patient. That's why apart from you are assessing the respiratory system, we are also assessing whether this patient have another problem, including the heart. If the heart has limited function, we have to prepare when we are doing the weaning. These cases will increase weaning in this cardiac dysfunction. So we have to prepare that also. Okay. Other than the heart, we see other comorbidities also influence whether we could win or not. Whether we could win or not, it is proven not delayed by comorbidities, but the successful of the winning XBT are influenced. So sometimes we want to win the patient, but after we try to win the patient get worse, not because of the winning process actually, but because of the comorbidity that the patient has. So comorbidity is one of the major determinant of winning failure and mortality. We should consider it as a risk factor for the patient if we are doing the weaning process and extubation later on. Other than the comorbidities, previously we already discussed about the sedation that the patient going to have when the patient is mechanically ventilated. We are trying to limit the sedation. Why we are trying to limit the sedation? So we have better understanding whether this patient could breathe by himself or not, including the use of muscle relaxant. If the patient is under muscle relaxant and the patient cannot breathe because of the muscle relaxant, we are going to be delayed from the step of weaning. So we are trying to limit the use of the sedation. We are trying to do a duration of the sedation daily, so we can assess the patient whether this patient could be weaned or not. Okay, and the drug that are most popular for the sedation right now is the dexmedetomidine because they are considered to have shorter weaning times and reduce anxiety, agitation, and delirium compared to the traditional sedation. In my hospital, we are still using midazolam and morphine, so hopefully we can change to dexmedetomidine to have a better outcome when we are doing weaning and extubation. Okay, about weaning, we also think what mode of ventilation is the best for weaning. Actually, there's no best mode of ventilation, but what we are trying to look at, there are a lot of options, a lot of mode of ventilation that we could use when we are weaning, such as the SNT, pressure support, and the type is CPAP, ASP, then the PAP and NAPA also. But what we are trying to say, what of mode of ventilation, we are trying to decrease the power or the ventilator driven power for the breathing of the patient, then we could use any mode of ventilation. And although some research suggested SNV has a bad outcome compared to PSV because probably they are comparing if you are doing SIMV, they are delayed and in reducing the load from the ventilator to the patient, and sometimes you have more dysynchrony compared to the PSV. That also contribute to the delay in weaning because the patient become agitated, not comfortable. So the patient with breathe not comfortable. So we think that the patient is not ready to wean. That's one of the research concluded. Other mode of ventilation that are popular right now is the closed loop ventilation. If you see, closed loop ventilation could help us in weaning the patient because when we are doing closed loop ventilation, the ventilators will do the weaning by himself based on the target that we set. So doesn't need for us to lot do intervention of the setting of the ventilators, but from the point of the effect of using closed loop ventilation, we don't see any decrease in mortalities and ventilatory days, but we see the decrease in the work of the nurses and the doctors in doing the adjusting for the ventilators. But in the future, maybe we see another research about the closed loop ventilation. Okay, after the weaning, we'll try to do the spontaneous breathing trial. A lot of ways we could do SBTs. The interesting part of we usually do the TPs or T-tube or the PS low PS. The other option is we are doing PS with PS0, PIP0. The better part of this method is we are mimic the post-extubation condition, but we still can monitor the breathing of the patient. The fraction of this oxygen also can be controlled. This is why from our view is the advantage of using this method. If you are doing SBT, there are some recommendation from the AARC. So RSBI not indicated to assess whether this patient could be SBT or not. You ask to do the complete assessment at before noon because before noon you have a lot of people. Then you could assess whether you could proceed with the extubation or not. And you could use PSV or TPs, which either have the same result, and try to maintain the FiO2 levels when you are doing SBTs. Do not increase the FiO2 levels because it will mask the underlying condition and give you a false positive results. Okay, you can do SBTs, and after you are doing SBTs, if you have the patient who are not tolerate the SBTs, you will find a lot of subjective criteria and objective criteria. If you find this in your patient, then the patient is not successful SBT. You can move to the ventilation or back from the previous one. Then try to look what the cause. Some causes are included in airway function or the lung function. In other causes, the cardiac function. Other causes is the cognitive function also. Other causes is the metabolic and endocrine function. Other causes is diaphragmatic function, and other causes is the nutrition. Based on these causes, you have to do intervention according to the cause. By doing the intervention, hopefully you can try to SBT in another time, and you will have a successful SBT afterward. Okay, we are proceed to the extubation. Why I still separate extubation from the weaning process, because of different flow when we see when we are trying to separate the weaning from the extubation. We could have a fate of weaning, but we can have a fail of extubation, but still have a successful weaning because we could have a lower ventilator drive from the ventilator, but the patient will advert to other system to make sure that the patient can breathe without endotracheal tubes, such as the tracheostomy. Okay. Okay. RSBI is a good indices, but if RSBI alone is not good for successful extubation, it's good for reading, but it's not good for extubation because we need other parameters. So we are looking at the data that were concluded by Torni and friends. They are trying to few other indices that could forward us to successful extubation. There are 12 independent factors. If you see, most of the factors are considering about the function of the lung. Why is there? We need another indices from the machine learning that we've done by the people at Shanghai. We see other indices, including the airway indices. So based on this case and this article published by the Neurocritical, we are trying to make some predictors whether the patient ready to extubate based on the two conditions, on spontaneous breathing capacities and airway protection. This is quite important because if the patient can breathe but cannot protect its airway, the patient will have a failure to extubate. So we need to look also about the airway protection. And after we assess all the patient, including the lung and the airway protection, we are trying to look at what the risk in our patient. Is it low risk, intermediate risk, or high risk based on these indices? Okay, based on that risk, we are trying to provide more support after we extubate the patient, whether we are going to do high flow oxygen therapy or NIV after we extubate the patient. We are preparing this before we are extubating the patient. Okay. Okay. For the summary, when we are doing we're doing weaning and extubation, all patients receiving ventilator support should be assessed for their suitability for weaning and extubation. The assessment components are spontaneous breathing capacity and airway protection. Based on this assessment, we will classify the risk and provide supportive measure to intervene and manage the patient for successful weaning and extubation. So from the path that we showed previously, it's not that easy to do a successful weaning and extubation if we are not readily to assess and provide more support after the extubation. That's all from me. Thank you for your attention.
Thank you so much, Dr. Audrey, for sharing with us on the various considerations when it comes to weaning our patients from the mechanical ventilator and how to assess for extubation readiness. Yeah, so we have come to the end of all the 4 talks from our speakers. Thank you so much for the excellent and thought-provoking presentations. We will now move on to our 30-minute combined panel discussion and Q&A session. We continue to invite participants to submit as many questions as possible via our chatbot, and we'll try to address as many as the time permits. First question that I see in the chatbot, I believe, is for Prof. Dita, asking what's your opinion on using asymmetrical high-flow nasal cannula interface like OptiFlow Duet?
Okay, it's a very nice question. So actually, we commonly use the symmetrical high-flow nasal cannula, but I believe the OptiFlow has produced an asymmetrical cannula prong for certain of patients. We know that some of our patients don't have always asymmetric nasal area or nasal hole. So I think it seems like more comfortable for the patients. And also the asymmetrical prong from the cannula can promote the higher flow from the smaller prong. So it can promote the more CO2 removal, while the ventilation oxygen comes into the patient from the larger prong. So what the result is, it can produce better CO2 removal, at more comfortable for the patients, and also can decrease work of breathing, and maybe decrease minute volume. So I think for some patient has a better outcome. That's my questions. And that's my answer for the questions.
All right, thank you, Prof.
Okay,
Think-
so I think our next questions is for Dr. Sim Wen Yuan about the steps on calculating occlusion pressure. Maybe, Dr. Wen Yuan?
So I think the idea is that you're performing an expiratory occlusion, and the patient is then taking an inspiratory effort against the closed airway. So for example, if the patient is on peak of 5, at expiration is minimum auto peak, your pressure should be 5. You perform the occlusion, the patient breathes against the closed airway, and you measure the drop in airway pressure during that expiratory effort. So for example, if baseline peak is 5, the pressure drops to -5, then your delta is 10. So that's your occlusion pressure of -10. And then if you're using that to calculate your predicted delta PES, it's 2/3 of that 10, so 6 to 7. So that's your marker of your expiratory effort. And then if you're then using that to calculate your dynamic transonic driving pressure, you add the pressure support or the P peak minus P. So, for example, if the patient is on PS of 15/5, your pressure drops from 5 to -5, that's delta of 10. By 2/3, that's 6 to 7, and you add 15. So that becomes 21/22. So that is your dynamic transonic driving pressure and your marker for lung protection. Yeah. Hope that addresses it. Yeah. I think it's tricky. It depends on the ventilator you're using. Some of the ventilators allow you to do expiratory occlusion in PSV, and you measure the absolute pressures. Some vents don't allow you to do it. You need to use the NIF function. So I think, like, for example, the PB as well as the cascade, you need to use the NIF function, but you're not measuring a NIF, you're measuring a PO. Yeah. So it really depends on the type of ventilator you're using. Yeah.
Right, yeah. Thanks, Dr. Sim. And the next question, addressed to all speakers, for your opinion, for patients with ARDS, what's your opinion with regards to using pressure controlled mode versus volume controlled mode in reducing lung and diaphragmatic injury? Maybe we will get Dr. Sewa to answer this question first.
Hi, thanks. I think intrinsically, both modalities have been used in various ARDS centers. So I don't think there's an inherent superiority over one modality over the other. It's really for you to see, for you to know what is the changing variables and what are the pressures that you need to monitor to form in the different mode. For us, when we are initially managing the patient, in SGH in my center, we tend to want to have a better control of the tidal volume and driving pressure, and the patient may be paralyzed as well. So in this setting, they're generally in the initial phase on volume controlled kind of a modality. And then subsequently, as we start to let them come off the ventilator, come off the paralysis and lightening the sedation, generally we switch them over to pressure kind of mode, where the respiratory time, draining pressures, and the rise time can be a little bit more responsive to the patient's need as compared to a volume controlled mode. So they tend to have a less desynchrony issue. Yeah, so that's generally how we transition this patient. Happy to hear what other centers do as well.
Would maybe we'll invite Dr. Audrey as well. Maybe can share with us on perhaps your center. What do you normally practice?
For ARDS or any kind of patient with mechanical ventilation?
Seems like for this question is mainly for patients with ARDS.
Okay. Mostly I do the pressure control, mostly pressure control, but from the pressure control, what is important that we see whether our pressure generate not that high of tidal volume and not that low of tidal volume. So we will be adequate to achieve a better ventilation for that patient. But usually our hospital, because it's a teaching hospital, we are trying to do based on the pressure that we give, based on that mode of ventilation. We are trying to limit the pressure that we give. That that why we are using the pressure controlled ventilation. Even though with pressure controlled ventilation, you still need to measure what the plateau pressure are, but usually we are doing the plateau pressure controlled ventilation. And at some cases, we also use volume controlled ventilation if the pressure is not that high. If the pressure is quite high, we usually convert to the pressure controlled ventilation. Trying to not achieve high pressure, but the main part is we are trying to limit the tidal volume based on that pressure also. We are usually you do the pressure control filtration. Thank you.
Okay. I think you can move on to the next question. There's this question, but it's actually not about ventilation, but I think it's also with the ARDS questions. Maybe if it's okay for you to answer, what steroid to use, dose and duration in ARDS. This question is for Dr. Sim Wen Yuan, I think, but maybe from other centers could also give the answer. Dr. Sim?
Yeah, so I think the question of steroids in ARDS and what dose is I don't think there's a fixed answer. Really depends on the cause of the ARDS and whether things will be responsive to steroids. I think so. I work predominantly in the medical ICU. A lot of our patients have CAT, a commonly called pneumonia, septic shock as the cause of ARDS. So in those patients, I tend to use hydrocortisone. The dose I usually start with 50 mg Q6, which is I guess consistent with the Cape Cod study, and also what the dose that was used in many of the septic shock trials. So that tends to be the dose I've used. I've not personally used metalpred. On occasion, if the patient doesn't have a severe CAP or septic shock, then I've considered using the DEXA ARDS dose, although that is a lot higher than the Cape Cod dose. I think that's DEXA, if I'm not wrong, it's 20 mg 5 days and 10 mg for another 5 days. But that I use that less often. Yeah. I think the data probably should use it a bit earlier in the course of the disease than later. Yeah. That's my personal approach, but I don't think there's a lot of evidence either way. Yeah.
Thank you, Dr. Wen Yuan. Professor Dita, do you have any opinion on the matter?
Yeah, I think after COVID pandemic, I think we're moved from only using methylprednisolone for ARDS to another steroids. For example, like we used to use methylprednisolone for ARDS around 1 to 2 milligram per kilogram per day. And after COVID, we start to like modify the steroid. So we began to use hydrocortisones as well as the septic shock dose. And also we use dexamethasone, 5 to 6 milligrams for adult patients. So I think there is a place for the steroid, and it's not only methylprednisolone anymore, but it's moved to another steroid like hydrocortisone and also dexamethasone with clinical proven benefits. I think that's my answer.
Okay, thank you. But as I just saw another question regarding the methylprednisolone. For the pulse dose of methylprednisolone, what do you reckon about that? Is it useful for ARDS or is it harmful?
Pulse methylprednisolone usually being used for prevent rejection in transplant patients, as far as I know. But for ARDS, I think the recommendations of the doses is around 2 milligrams per kilo body weight per day for 7 to 14 days, according to the patient's severity conditions, I think. I don't know if other speaker has experience with the post methylprednisolone for ARDS.
Maybe Dr. Sewa, do you have any opinion on the pulse dose methylprednisolone in ARDS?
So assuming that when you say the pulse methylprednisolone, you are thinking about the really high the dose that we use for some of the um, autoimmune related condition where you go up to 500 milligrams or even to 1 gram for 3 to 5 days. I think the evidence for high dose steroids in the early 1780s has been associated with higher risk of complications as well as mortality. So generally, the people have moved away from high dose steroids, including pulse methylpred from prednisolone. So that's not something that I would advise to use. If you're considering steroids, it will be more on the equivalent dosing of around methylpred 1 to 2 milligrams per kg per day.
Okay, I see another interesting question. I think this question is to Dr. Audrey. What's your comments for those patients high risk of extubation? Would you extubate them to high flow nasal cannula, or would you extubate them to NIV? And is there a reason for your choice?
Okay, thank you. Actually, the reason, part of this reason is not scientifically, because in our hospital, we do have ventilators that could do NIV, but the mask and the adjunct is quite limited. So we are trying to mostly we do post extubation with high risk using the high flow oxygen therapy or high flow nasal cannula. But in some cases, if we see the problem is caused, for example, by the heart function is not that good, we need a higher peak. Well, we will try to look for the NIV compared to using high flow oxygen therapy. If the problem is you need big higher oxygenation in some cases, we use high flow oxygen therapy. If we have a patient with limited ventilation adequacy, we still could use high flow oxygen therapy, but it is better if you use if you use non-invasive ventilation. So based on my hospital, we are accustomed to use high flow oxygen therapy compared to the NIV. But for the theoretical, if the problem is ventilation, I will choose NIV, or the problem is we need to have higher beat positive pressure for the lung, we will use NIV compared to the high flow oxygen therapy.
Right, yeah. So sounds like it depends on, the patient's actual underlying clinical condition, whether the patient has underlying heart failure or things like that. And we tailor it according to, the patients, right? Yeah.
Okay. There's a question for all the speakers about back to the mode of ventilation. How do you think about APRV in ARDS? Do you use it often or not, maybe. Maybe Dr. Adri, can you answer first?
Sorry, what's the question? I'm typing the answer for another question. Sorry.
Okay.
APRV,
APRV. What's
APRV.
your experience using APRV in ARDS in your ICU?
Okay. Back when in COVID pandemic, we are to do APRV because we see the patient is not good lung function. We need to have high oxygenation. We need to recruit more lung. That's why we are using APRV. Some patients have good results, but the problem when we are using APRV because not all involved in the taking care of the patient know about APRV. They are sometimes having doubt whether this APRV is safe or not. But uh, the problem with the RPRV, in my opinion, about the winning process. Actually, the PRV have their own way of winning process. We are trying to decrease the length, the inspiration time length to the as part of the winning process. But they are worried whether this the patient is already in the good condition or not. That's why we switch from ARPRP when the oxygen fraction and I say the uh, PaO2 is getting better. They are switching to the common mode of ventilation, such as SIMT or pressure support. But in my opinion, it's quite good mode of ventilation for patient with low recruitment of the lung. Because when you are doing a PRP, you can recruit more lung because you tend to decrease the recruitment of the lung. But the other problem that we face, if the patient have not that good hemodynamic as and blood pressure with the high dose of vasopressors, we are afraid whether the epilepsy could uh, uh, disturb more lower blood pressure because of the decrease in preload because of the high thoracic pressure. But apart from that, I still recommend using APRV in the if you see the patient is recruitable, like I think Dr. Dewa already explained about that whether this patient is recruitable or not. So if the patient recruitable, maybe you could use a PRP. Thank you.
Dr. Sewa, maybe you can share your opinion on the APRV.
Thanks for the questions. Our unit doesn't use the APRV very often. Partly it is because of culturally, the APRV is not a modality that's familiar with many of the physicians. Similar to the earlier the speaker, our unit is also ran over the night and also during the holidays by non-intensivists helming the ground. So having a modality that is a little bit more unfamiliar to them may be a challenge. Although conceptually, the APRV with its open lung concept and allowing for spontaneous ventilation do sounds attractive, and there are many the centers, expert centers that are using it with great result. And of course, centers that, for example, in Habashi, the unit, they have published quite a few um, high impact publications on their experience of using the APRV. So I think there are in expert users definitely is something that can be used. Whether that is superior to other the technique, especially in the setting where you are trying to do personalized mechanical ventilation is unclear. The fact that it's not adopted worldwide do suggest that I think the efficacy is still in debate.
Thank you, Dr. Sewa. Yes, I agree that using the less familiar mode of ventilation might put the patient more at risk if we, especially in the off hours in the ICU when the intensivist is not in present. So yes, maybe Dr. Yiting, the next question.
I think we are running short of time, so we will take one last question before we conclude today's session. Last question, I see a question in the chat board. What's your practice in stridor management post-extubation? If the patient is not responding to adrenaline nebulization and IV dexamethasone 4 mg. Maybe Dr. Wen Yuen, would you like to take this question?
Yeah, well, I guess if you're just clearly failing despite whatever you tried, then you may not have a choice but to reintubate. I mean, yeah, I guess the idea is potentially to try to assess the patient before extubation to see whether you think the patient is at high risk of post-extubation stridor. Do a couple test if the patient is at high risk, and then give steroids preemptively before you extubate. But I guess in these patients, the higher risk, you need to be prepared that they may fail, and if they don't respond to the adrenaline and more steroids, then early intubation is probably required. Yeah.
Yeah, completely agree. Okay, all right. The time now is 4:36 p.m. We will conclude today's session. The rest of the questions that's posted in the chat board, we can we can type it out, type our answer out in the chat board, and we'll try our best to still answer them. As we conclude today's session, I would like to sincerely thank our four speakers for sharing your expertise so generously with the audience today. And also thank you to SICM and ISICM for organizing this collaborative educational session. And of course, to all of you participants for taking your time off your busy clinical schedules and also precious weekend to join us today. So before we close, just like as a quick reminder, please remember to fill up our attendance form, which is shared in the chat board. Filling the form will allow you to, if I'm not wrong, receive your certificate of attendance from the Indonesian side, and it can also help us to improve future educational activities that we organize. And while we have everyone here, I also like to take the opportunity to highlight an upcoming event that many of us are looking forward to, which is APICS 2026, for which for the first time it will be held in Bali, Indonesia. So this event will be a fantastic opportunity for critical care colleagues from across the region to come together, share our knowledge, and strengthen collaborations. So we hope that many of you will be able to join us at the event. So once again, thank you all for your time and participation today, and have a wonderful day ahead. We'll close the session today. Thank you.
Okay.
Thank you very much, everyone.
Thank you very much, everyone. Have a nice day.
Thank you.
Looking
Nice
forward to see you
day.
in Bali.
Yes,
Yeah,
we'll
hope to
see
see
each other
everyone
in
in Bali.
Yeah.
Yes, and for all the participants, you can revisit all the lectures also in the YouTube channel in Perdici Official, PERDICI. Thank you very much, everyone.
Okay.
Enjoy the
Thank
rest of your
you.
day.
Thank you. See you. Bye-bye.